Thank you. I'm Jun Seok from Gyeongbuk National University in Korea. Before starting my presentation, I special thanks to the Katsin for having me here. It's a really beautiful and well organized conference. So today I gonna talk about the robotic colorectal surgery. So I divide my talk in four parts. So in the first and second part, I will share our hospital data and some initial experience. And in second part, I'm gonna share some future perspective and the indication of the robotic surgery in the treatment of rectal cancer. So as you know well, until now, there is no strong evidence supporting the robotic surgery in the management of colorectal cancer. This is a famous LOLA trial. It's performed by the UK, David Jane. And in this multi-center, multinational study, they evaluate the real benefit of the Da Vinci robot system. But if you look at their conclusion statement, they say like this: robotic surgery as compared with the conventional laparoscopic surgery did not significantly reduce the risk of conversion, and robotic surgery, when performed by surgeon with varying experience with robotic surgery, does not confer any advantage, no benefit in rectal cancer resection. So they did not show any benefit of the robotic surgery in the rectal cancer surgery. In the similar line, in Korean multi-center consortium was made in 10 years ago. So Professor Choi and Seonan Kim and the Severance Hospital, we made some multi-institutional consortium to evaluate the real benefit of robotic surgery in the rectal cancer surgery. The name is the COLA trial. This is the superior, based on superiority design. So we hypothesize that robotic rectal cancer surgery is better than laparoscopic surgery. So our endpoint is TME confidence. The standard value is 75%, and the superiority margin was 9%. So this slide shows our primary endpoint. So in each case, we take a photo of the specimen after TME, and we collect all the photo data. And we also collect some intraoperative photo. So we want to check the pelvic nerve preservation in each case during this trial. This is the study flow chart of the COLA trial. So altogether, 325 patients allocated in robotic surgery and laparoscopic surgery, half and half. And this is the short-term result. So operation time is significantly longer with the robotic surgery. It's almost 50 minutes is longer with the robotic surgery compared with the laparoscopic surgery. And if you look at the conversion rate, it's very low in both groups, and there are no difference in between them. And protective stoma rate is high in robotic group, and complication rate, morbidity, mortality is same in both groups. This table shows the histopathologic data in our trial, and we focused on TME completeness. This is the endpoint of the COLA trial, and there are no difference in both groups. But when we do some subgroup analysis, we find some interesting data in lower rectum. If you take a look at the lower rectum data, the TME completeness rate is superior, better with the robotic surgery compared with the laparoscopic surgery group. Except this data, everything was same in both groups. And this is the subgroup analysis of the the risk factor about the quality of TME. So if you take this photo, we can find that if we with robotic surgery in male patient, advanced tumor, and high BMI patient, we can get better result. But this does not reach the statistical significance. We can just find some trend. So in subgroup patient with male patient, low rectal cancer, and high advanced tumor, robot is a good option. And we expect the better outcome in functional outcome. For example, sexual function, genitourinary function, because we hypothesize that robot provide better view and the stable traction because we can preserve more nerve. But unfortunately, we cannot find any difference between two modalities. And the next one is long-term data. Long-term data is under our waiting submission. I believe we can publish next year. So median follow-up is more than 70 months, and we analyze local recurrence, disease-free survival, and as we expect, there are no difference in terms of oncologic outcome between robot and laparoscopy. This figure shows the local recurrence between two options. Next one is I'd like to talk about the indication. As I told in the first part, many ROLA trial, COLA trial failed to show the real benefit. But in Korea, unlike United States or Japan, we Korean surgeons are faced the cost burden because it's not covered by government national insurance. This is data from the 9 years ago. Professor Choi and our group performed a small randomized trial for right colon cancer. So this is the cost and comparison data. At that time, it's the same in current until now. If you look at the total cost data in Korea under the Korean payment system, is almost 1.5, almost 2 times higher if we use the robotic system in right colectomy. So this is at that time we conclude that the robotic surgery is no benefit in right colectomy. So now in our institution, my personal practice, I do not strongly recommend the robot surgery to my patient. So because I think laparoscopic instrument is enough for CME and bowel mobilization and safe anastomosis. So in my personal experience, I do not strongly recommend the robot system in right colectomy. And the second one is lateral pelvic lymph node. This is the data from the Tokyo University Professor Ishihara. So in Japan and in Korea, the lateral pelvic node dissection is a standard protocol in advanced rectal cancer. In our hospital, we usually perform pre-op chemo radiation. So I'd like to explain the indication of our institution. So we checked MRI before radiation and after radiation, but the priority has the before MRI is an important tool in determining whether we perform the lateral node dissection or not. So I think lateral node dissection is a very best room for the robotic surgery because as we can see here, during the lateral node dissection is a confined, narrow operation space, but at the same time, we should preserve the obturator nerve, ureter, and some vessel. So we need a detailed motion. We need the sophisticated dissection. So the technical benefit of the robotic device, such as the wrist function, and a stable traction is the best place for the lateral node dissection. So I strongly recommend the robotic surgery for the patient who require lateral pelvic node dissection. Next one is a very low rectal cancer. So in Korea, as I showed the data about in the COLA trial, in Korea, especially in our center, APR rate is less than 7% or 6%. In most patients, we are trying to preserve the anal function. So ISR is a very common procedure in Korea. So I think the ISR is the best indication for robotic surgery. This is the right side is the transanal ISR performed by Professor Choi, and right side is the laparoscopic transanal team. So if you compare the two approach, robotic is the better option for the intersphincteric dissection. This is another indication of robotic surgery. So personally, I recommend the robotic surgery in some complex case. This patient has a diverticulitis with some fistula with the bladder. This is one of good indication of robotic surgery because we need the sophisticated suturing or more dissection. So this is one of good indication of the robotic surgery. The final topic is about the future perspective. So in our hospital, Professor Choi and their operation team started a single port Da Vinci SP surgery in the TME and lateral node dissection. I think today morning session, Professor Choi will talk about this more in the tomorrow. So I will skip in this session. This is the final wound view after the SP system. So we can make better outcome with the single port robotic surgery in the future. This is until now the data from our institution with the single port robotic surgery. So in summary, so far there is no strong evidence or data to justify the cost of robotic surgery in Korea. So indication is important. So as I showed, the ISR, lateral node dissection, or some conflicted case, robotic is a good alternative option. But a right colectomy or anterior resection, or in usual case, I do not think is a better option. But in the future, technology will get improved. So I think the robotic surgery is a thing on the near future. Thank you for your attention.
As you show us about the current evidence in the literature, I think it's actually is not easy to show by the number in when you compare the good operation with a good operation. It may be difficult to show in statistically or by the number, but as you show and Professor Shea show, if you do is good, as we believe the outcome is very good. Yes, and actually, and you show us about the cost effective. I think cost effective may be in different country, maybe in different view. If you show cost effective for your country, maybe different with the other country, even our country in our regions. Yes, thank you. And have some question from Isaac, please.
Yes, thank you, Professor Park, for the excellent talk. My question, I think all the studies have shown not considerable differences between laparoscopic and robotic surgery. And I think we can all agree in the hands of a master surgeon, like yourself, laparoscopy and robotic surgery have very little benefit, right? But the area which is seldom talked about is ergonomics for the surgeon, right? You need a lot of data to show a bit of difference in maybe TME status or distal margin for robot and laparoscopic. But you need one case only to show the difference between the comfort of the surgeon between laparoscopic and robotic surgery. So the question is, why do you think we cannot use ergonomics to justify the cost and for surgeon comfort and longevity in the careers? Because it's very important, don't you think? Thank you, Professor.
I think this is a very important and a good question about our trial. I think that in Korea trial, in study performed by in our nation, Korea, the surgeon who participate in this trial already mastered the technique with the straight